the JAMA Network.
Hi, my name is Tracy Wong. I'm an Associate Professor of Medicine at Duke University and the Duke Clinical Research Institute. We know that sudden cardiac death is not an infrequent phenomenon. In the U.S. alone, more than 300,000 patients have sudden cardiac death. And a previous study actually found that among patients who've had a cardiac arrest, more than 80% of these patients were eligible for an ICD but did not have an ICD implanted before the event. So for us, we particularly wanted to focus on an older MI population. These are patients who had an acute MI, an ejection fraction that was less than 35%, who might have been candidates for ICD therapy, and to look at the rate of ICD implantation within the next year, as well as the 2-year mortality rate associated with an ICD implant. We started with Medicare participants in a nationwide registry called Action Registry Go with the Guidelines. This is a registry that captures consecutive MI patients, and focusing on the Medicare population allowed us to link it to Medicare outcomes long-term so we could look at post-discharge ICD implantation rates and their long-term outcomes. This now involves about 10,000 patients or so discharged from hospitals across the U.S. We were then able to look at how many of these patients got an ICD within the next year, and then look at their outcomes even out to 2 years. Among these 10,000 patients, surprisingly, we found that only 8% of these patients went on to receive an ICD within that first year. This is a surprising rate given that we thought many of these patients might have been eligible for these devices. Now certainly there might be some patients who would not have qualified. So for example, patients who've had previous cancer, previous stroke, end-stage renal disease. These might be factors that might give a physician pause in terms of deciding that an ICD should be implanted. But even after we excluded these patients from the population, we found that the implant rate was still about 1 in 10. We then went on to look at what their outcomes were after device implantation. Patients who received an ICD implantation had a lower 2-year mortality compared with patients who did not receive an ICD implantation. After adjusting for many of the differences in patient characteristics between those who did and did not get an ICD, we found that the risk of 2-year mortality was 1/3 lower among those who did get an ICD. ICD utilization was pretty low in patients who were 65 and older and had an ejection fraction less than 35% after an acute MI. We also looked at the very much older patients, so patients who are 80 years or older, and again we found a similar association between ICD implant and 2-year mortality. For us, what we've pointed out as a gap, what we've said is 1 in 10 patients are getting a defibrillator. So where do we go from here? I think one of the key things we've highlighted is that care transition process. That is so important to being able to coordinate a patient's care, particularly if they need that kind of follow-up. We need to make sure patients have follow-up appointments made. We need to be able to educate patients to say, this is important to you, this is what might be life-saving for you, making sure that they see this as a priority as they go on. One thing I do want to mention is defibrillators is not for everyone. Some patients may feel that the trade-off here, the risk versus the benefit of having an ICD, is not necessarily worth it to them. So this emphasizes that need for that individualized patient-provider conversation to say, what we're trying to do here is the right thing. At the end of the day, what we're trying to do is identify opportunities to optimize the ICD use and put it to the use so that our patients are getting the most benefit from this intervention.